Okay.
All right. Looks like it's 12:05. Thank you everyone for joining. We're going to go ahead and get started. Just a reminder before we get started to please go ahead and, if you haven't already done so, rename yourselves with your full name and your organization name. That way we know who you are. We can track attendance. Thank you very much. My name is Masood. I'm one of the coordinators for Project Reach here with y'all. And our presentation topic today is going to be caring for the technology dependent child. So welcome everyone again. I'm going to go ahead and get my screen shared. All right, is everyone able to see my screen? Thumbs up, yep, head nod. Okay, sounds good. Gonna go ahead and full screen this. Okay. All right, so just going to go over a few general housekeeping announcements before we get formally started here. So going over the initial disclosures, Project Echo and Reach collect registration, participation, and chat comments. This data can be used for reports, maps, communications, surveys, quality assurance, evaluation, and to inform new initiatives. Your individual data is going to be kept confidential. And for educational purposes, we do record these sessions and it'll be available on our website for all participants to be able to go back and see. By participating in this session, you're consenting to be recorded, and we definitely value and appreciate all participation. All participation is welcome. If you have any questions or concerns, please feel free to reach our email address at reach@lmhpco.org. So we are accredited by LMHPCO to provide CEU credits to those who are interested. All you need to do is complete the email survey after this session that'll be sent out to all of you to get credits, and you should be receiving that email survey after no more than a week. So be on the lookout for that. Just some general Zoom etiquette. So be sure to mute your microphone when you're not speaking. Remember to unmute when you want to say something. And speak closely and clearly to the microphone so that we can all hear you. Keep your camera on if possible. We would love to see all of your faces. And again, if you have any IT issues, please feel free to use the chat, or you can send an email out to reach@lmhpco.org. Again, just make sure your name is correct. So full name and organization name so we can keep attendance and make sure you get that survey email. And just you raise your hand if you'd like to speak, and you feel free to use the chat as well. This is a safe space, so we definitely appreciate everyone's questions, thoughts. All concerns are valid and valuable. We definitely want that input. Take space to make space, and what's said here stays here. So with that, I am going to turn it over to Dr. Autry for the agenda.
Hi, everyone. I'm Dr. Autry. I think I know most of you guys. I'm one of the pediatric palliative care physicians at Children's Hospital New Orleans. Just wanted to start by introducing myself. The agenda will start with introductions for everyone, and then we'll briefly look over the objectives for today, and then we'll have our didactic presentation and go through a couple cases that are pertinent to today's topic. And then we will wrap up with our mindfulness activity. Go ahead to the next slide, Masood. Okay, so for anyone new, I'd like to welcome y'all to our REACH initiative. This is the Gulf States Palliative Care Consortium REACH, and there's also a REACH community out of St. Jude in Tennessee as well. So we're excited you're here. And then for returning peeps, we're happy to see y'all. I'm going to go ahead and let everyone introduce themselves now. We'll start with the rest of the REACH project members. I'll punt it over to Masood, or I guess Masood, you introduced yourself at the start. Okay, I'll start with our presenter, Stevia, who may look familiar to many as well.
Hey y'all, I'm Stevia. I'm the nurse practitioner on the Pelican crew here at Children's New Orleans. And also, I'm going to be co-presenter today with Shauna. So I'm going to punt it over to Shauna
Hi, I'm Shauna. I'm the respiratory therapist. I do all the trach vent training for our technology dependent kids.
Stacy?
Good afternoon. I'm Stacy Melling. I do integrative therapies at Children's Hospital in New Orleans, work very closely with the Pelican crew and the patients that they see. Thank you.
Thanks, Stacy. Okay, I'm just gonna go through with the peeps on the list. First is Lisa Baumgartner. Lisa, can you hear us? Okay, I'm gonna skip to Katie.
Hi, I'm Katie Helo. I am a nurse practitioner in Baton Rouge at Our Lady of the Lake Children's Hospital. I do palliative care for the hospital, and the other half of my time I work with the St. Jude Affiliate Clinic.
Thanks, Katie. Anne Marie?
Hey, sorry, I was having a technical difficulty there. My name's Anne Marie. I am with Allegiance Hospice and Palliative Care in East Central, and I'm the assistant administrator and also serve as the director of clinical operations.
Thanks. Judy? I'm gonna go to Amanda.
Hey, I'm Amanda Babb. I'm the patient care manager for Allegiance Hospice in Marksville.
Hey, Amanda. Mandy?
Hi, I'm Mandy Benoit. I am the Regional Director of Clinical Services for Allegiance Hospice and Palliative Care.
Awesome. Seeing more Allegiance. Holly? Or Holly Sanders. I'm seeing two Holly, sorry.
Hi, Holly Sanders and Holly Doza are both here.
Oh, okay. Hey, y'all. Looks like both with Allegiance too.
Yep.
And then Laura sent in the chat. Laura, did you want to introduce yourself or just in the chat?
I can introduce myself again.
Okay.
I'm Laura Mooney. I am the regional director of quality outcomes for Compassus.
Awesome. And then Jancy. Or Yancy. I'm sorry if I said that wrong.
Oh no, it's Jancy. You were right.
Okay.
Hey, I'm Jancy. I'm a palliative care nurse practitioner here at Women's and Children's Hospital in Lafayette.
Awesome. Well, lots of familiar names and so happy to have y'all here. Go to the next slide, Masood. Or did we miss anyone?
Hey, I'm Jessica Graham. I am the administrator at Allegiance Hospice and Palliative Care in Ruston.
Awesome. Thanks, Jessica. Sorry I missed you.
That's okay.
Okay. You can go to the next slide, Masood. Okay.
Hey, Ashley.
Yes. Oh, yeah. Hey, Judy. I think we missed you when I came by your name.
Hi. Yes, I'm sorry. I'm driving. Technology difficulties. I'm Judy Zarang from Children's, and I'm very passionate about palliative care and looking forward to today's topic. Thank you.
Thanks, Judy. Okay, so today's topic is caring for the technology dependent child, and we are lucky enough to have Shauna and Stevia here with us today. So Shauna, as she mentioned, she's a respiratory therapist here at Children's Hospital in New Orleans, and she's been here for 21 years. So we are so lucky to have her expertise. And as she also mentioned, she's been providing trach and vent education to those families for the past 12 years. So we will hear more about her on how to best care for our kiddos who have respiratory needs at home. And then Stevia, as she mentioned, is our pediatric palliative care nurse practitioner here at Chonola as well. And she has over 5 years experience working with hospice and palliative care and often coordinating that care transition from the hospital to the home. So I'm going to go ahead and let them take it away.
All right, thank you, Ashley. Next slide, please. So our objectives for today are to highlight devices that are often encountered in pediatric hospice patients. We're going to discuss how to approach common complications with these medical technologies. And then we're going to review some troubleshooting tips that can be utilized in the home setting. And I'm really hoping that we can make this an interactive conversation, because the content is pretty dry. And if anyone's eating lunch, I know most of us are nurses here, but we do have some pictures in this presentation. So just a little disclaimer for you all. So we will start with central lines. And how many of y'all, like, you can say it on the chat or raise the hand or unmute yourself and say it out loud. How many of y'all deal with central lines when you have kiddos home with hospice? I see a thumbs up. Okay, so I'm guessing it's probably fairly common, and if it's not as common, we have some good refreshers. So starting, we have our subcutaneous port. That's the one where you're just really completely implanted into the subcutaneous tissue, directly under the skin, usually on the chest, but they kind of vary in where we put them. And then that's where we have like that Hubbard 90-degree angle needle that we use when it's accessed. And then we have next our external catheters. So that's where we have it tunneled under the skin. And then we have kind of the line still hanging out of the bottom a little bit. And we don't have to have a needle stick when we're accessing those lines. And then our PICC is our peripherally inserted central catheter, and that's through our arm. So all of these, when we are talking about a patient home with hospice, you know, can be very different than in the hospital setting where it may be getting accessed every day. So kind of the biggest thing that I always think about when we are talking about central lines and someone being home is like, when was the last time it has been accessed? And then how that might change how we are approaching any troubleshooting that we need to be doing. So all of our central lines dressing changes are every 7 days. That's our gold standard. And we will go through kind of some common troubleshooting techniques and recommendations. Any questions so far or comments on the different types? Okay. All right, we can go next. So some common issues that we have when we're doing central line troubleshooting are burning. The line won't flush or it won't draw back, and skin issues. So again, the burning will be mostly when we are trying to access that port, and if we're not totally have the needle inserted all the way, that's when you're going to hear that they're complaining of burning, and then you need to try to re-access the port at that point. When the line won't flush or won't draw back, we kind of do pulsatile flushing. So like really gently kind of push and pull. And then changing positions is really huge. So having them lay down or sit up, maybe turn their head dependent on what side the port's on, change arm position, yawning, coughing, those things can all kind of like help change the flow. And we don't want to push it, like if we can't push it all the way, then we just need to take a break. We're not trying to push really hard on these lines. And if you are, then it likely needs, you know, our cath flow or TPA. And then skin issues, obviously, with having those dressings on, and a lot of our kiddos are on various medications that can cause more sensitive skin or skin breakdown. We always are going to be watching for that. And I'd say the biggest trick to all of it is talking to the parent, because they often know the best position for accessing their child, or you know, what works best for their child. Next. So our big complications that we have with central lines, and the signs and symptoms that we're going to be looking at are things that as a nurse we're always assessing for, but number one is our bloodstream infection, and that's going to be associated with fever, chills, and systemic symptoms. 2 is our skin irritation or infection. So on the right, you can see we have a score 0, that's our healthy intact skin. And then when we're going to 1, we're just getting that little reddening around the site. And I know we clean our central lines with chlorhexidine. So that's our gold standard. So maybe at this point, checking in with the provider and seeing if betadine might be a better switch so that we don't progress into score 2 and 3 where it can get really painful for the patient. Usually at about score 2, we start using Polymem, which is that nice like padded foam to help protect that site, to help protect any more of that skin breakdown. And at 3, we have a lot of erosion and it's going to be really painful for the patient every time. And then that's kind of make that experience more traumatizing for them. So anything we can do to prevent getting to a score 2 or 3. If we don't have like, I don't know what the access is for y'all out in the field. The other option besides Polymem is just to use a split gauze, but that does need to be replaced every 2 days instead of every 7 days for the Polymem. I know sometimes we have back orders on supplies, so it's always good to have a second option. Next. Third is our line occlusion, which we kind of talked about a little bit before, where we have our difficulties flushing or drawing back, or we're unable to infuse our medications. So again, with the port, I always feel like that's the trickiest. Like, did I get to the back of the port? But sometimes if you feel like you've been to the back of the port, the needle like will separate a little bit and from the safety guard, and then most of the time you just have to kind of push it back in and that fixes the problem. But if you can't flush or get a blood return, you want to take the needle out and try reaccessing. And we always are using numbing cream with our patients. So you have a 2-hour window with the numbing cream, so they should still be nice and numb from the cream to not have any more discomfort from that. And then our next complication can be a line-associated clot. So then we're looking at extremity swelling, redness, pain, or it can be completely asymptomatic. Next. We also can have migration of the line. So that's where it's really important on our central lines to be very mindful of where, it's marked. Usually you have about a 2 centimeter grace length between where it was marked and where it might be coming out before that is still likely in the same place. So really checking that every single time that you are checking and using that line. You can also have swelling in the neck or chest during an infusion, pain or discomfort, no blood return, or leaking around the catheter site. And then there can always be a tear or hole, can be visible or not, maybe some wetness underneath the dressing or along the tubing, bulging, pinkness, puffiness, swelling. So all things that we're always assessing when we are using central lines. And we can go next. And so what, I'm sure you all have worked with central lines. What kind of challenges have you experienced? And you can just unmute and start talking.
I think what we've experienced a lot of is, we send patients home accessed with hospice, but then, they end up doing a little better than we think or thought they would. So they come back, to see us in the clinic, but past that 7 days, we tell them that we really should de-access and re-access. And I find we often get pushback with that, and I don't really know the right the right way to handle that. And each doctor is kind of different in how they approach it too.
That's a great case, Katie, because I know it happens commonly where like, oh, we'll be good. I think what in my practice, what I've done is, if it is going to be past those 7 days, like, and I'm trying to draw something, just wasting, like, normally it's 2 mLs, wasting more like 10 mLs, and really trying to get a great flush before, so that we're not having any of that old stuff in the line. But I think it's like patient by patient, provider by provider, and I don't have a standardized way of navigating that situation. I don't know if any of our hospice teams encounter that. All right, well, we will move on. Thank you for sharing, Katie. And next we will go into feeding tubes. So again, I would say that this is very commonly are sending our patients who are receiving hospice care with an NJ or a G tube. And if everyone can kind of do the hands, seeing how many people are taking care of patients with NJs, G tubes, feeding tubes. So we will briefly go over the different tube types, but I feel like we're all probably very familiar with them from our nursing background. So we have our NG tubes that are placed through the nose, down the throat, through the esophagus, into the intestine. And sometimes we can advance them to the jejunum as well. So then we have NJ tubes. Then we have the permanent surgically placed tubes. That's our G tube, our GJ, and that's in the opening in the abdomen where the tube's placed. That's our stoma. Once that's healed, it's generally not painful or bothersome whatsoever. The children can do their normal activities. And it's a great way to have consistent way to get medication or nutrition into our patients. You can go next. So here's just a picture. This is the picture on the left is a picture of like the low profile G tube or our Mickey. And those are typically changed every 3 months. On the right hand side, you'll see what it looks like, the set and supplies. And this was, we did use this photo from St. Jude, so they had a lot of specific things that their team uses. And you hit next. Oh, sorry. So this is what I was talking about. The picture on the left is our Mickey. That's the low profile G tube for accessing that I feel like we are typically sending our patients home with. You can do next again, please. So some troubleshooting, like what to do if the tube comes out. So general rule of thumb is that if the tube has been placed for longer than a month, it's mature, that stoma is mature. We don't have to worry about that kind of closing up right away. If it has been placed for less than a month, then it's not mature, and we do have bigger risk of, if we're trying to reinsert it, not getting it all the way into the stomach. So if we have a G tube that comes out and it's mature, we can try to replace that at home. If we have a G tube that comes out and it's not mature, you can try to place a Foley to keep the track open, and then go to the ED to get that replaced and double check that it is in the correct position. And then if you have a GJ or an NJ, anything that's going in past the stomach, that always requires you to go back to the hospital and get that replaced so that we can confirm placement that it is in the jejunum. We also, when we're thinking about a tube coming out and the urgency of replacement, why do we have the tube placed? So do we have it for bolus feeds, continuous feeds, or is it for medication administration? And is it important medications like anti-epileptics that we need to make sure that a child is getting on time? We can go next. So again, one of our common infection or common complications when we do have a foreign body and we have a skin is skin infection. So looking our left to right on our pictures is least severe to most severe, and monitoring for any redness or skin breakdown, and not really trying to avoid it progressing to the picture on the right. You can go next. Granulomas are another common thing that I feel like we see a lot with our patients with G-tubes. So we have our granuloma is new tissue that is usually like this beefy red and moist, or it can be kind of bumpy, that forms around the G-tube site. It can bleed or have like a yellow mucus-like drainage. And the cause of it is really just overgrowth of tissue due to the movement and that friction in the area, or it can be due to some of that moisture. It is not an emergency if you see a granuloma, even if it's like, this one on the left is fairly decent size. Sometimes they can get quite big and like beefy red looking. But again, not an emergency. You can use a special ointment, or sometimes they cauterize that excess tissue if it is kind of interfering with the function of the G-tube. If it is draining or bleeding, just placing gauze at the site is just fine. Next, we have leaking that can occur around the G-tube, and that's just because of the stretching of the stretching of the track, or if our tube's not properly secured. Or another big thing is always checking to make sure that that balloon that's inside and holding it in place is properly inflated. That does need to be checked periodically. Leaking can also be caused from the granuloma around the area, or the loss or gaining of weight, and then that tubing needs to be resized. And I feel like what we see most commonly is that loss or gaining of weight and resizing that tube appropriately. Sometimes some of our patients haven't had their tubes resized for years and they're still growing. So solutions around our leaking is just making sure our dressing's secure and the tube exits the abdomen at a 90-degree angle. Again, always checking on that balloon volume and calling the provider, and then potentially using a barrier ointment around the site to protect that skin. If we're having a lot of leaking, it's starting to irritate the skin. Next, we have G-tube clogging, and there's already a picture with an X through the Coca-Cola, and this is a safe, judgment-free zone. Who has ever used Coke on a clogged G-tube? I see it. 2 hands from Stacy. Did I get any claps from anyone?
And it worked when I did it. It was a long time ago, but it did work.
There's a reason why it came out that, to try Coke.
I'm sure. Who knows what else I messed up in the process? But in the moment, it worked.
Yeah. So,
it also dissolves battery acid. So,
yeah, right. So, do we really want to be trying to inject that in on some of our sensitive kiddos? But I hear you. Sometimes we have to get things in, get it going. So we always want to make sure that our tubing's not kinked or clamped, and often our families are clamping at the same point in the tubing all the time. So sometimes it's just rolling out that tubing and getting it round again. Then we're gonna try to always flush, and you do want to try to flush with like some more warm water, not hot or burning, but like pretty warm water, and try that pulsating push and pull motion. If that's not doing it, putting in some of the warm water and letting it sit for a while, it'll usually dissolve whatever is clogging it, but that is time. That's given a lot of time. Again, never trying to push any object into the tube to unclog it. And if we're still unable to clog it, you know, escalating it to the provider to help troubleshoot, probably have to replace the tube. And next, so what challenges have y'all experienced with feeding tubes, if any, or do they always function all the time just as they should? I know I always get a little leery when we're sending our toddler patients home and they have their NGs and they're all over the place and so excited. I'm always worrying about the placement once they get home.
I think that's the biggest thing for us also, the placement. And then if the G tube comes out and the family is newer to having the G tube, most of the time they don't know. And some of our nurses are intimidated by that.
Mm-hmm.
So that's part of it, I think, also too.
Absolutely, yeah. If we're not used to this technology, we're going home for the first time with it, and it could be a very traumatizing and scary experience. And so how do y'all kind of help support and train your nurses to become more comfortable with that? Or do you kind of have some that are and they kind of tend to the G tubes when they come out?
That's typically how we have handled it, is that the nurses that are more comfortable with it will take those patients. But going forward in the future, we will build that education so that those nurses can do ride-alongs, help other nurses to see just how non-intimidating it can be.
Yeah, that's awesome. And do y'all replace NGs in the field, or do you direct them to the hospital?
So I think it's just a variant. Typically we don't like to take NGs only because the placement can come out and that causes, you know, a bigger issue.
Mm-hmm.
But if it's absolutely necessary, we would get with the doctor and determine what would be best for that patient, not necessarily make a decision right then and there.
Okay, awesome. Thank you. Thank you for sharing. All right, so next we will move on to VPS. So our VP shunts, which are another common thing. I think we have a lot of our babies that we send home with. And so the VP shunt, the function of that is to drain the extra CSF that circulates around the brain and the spinal cord, and it helps alleviate that pressure in the brain from it building up. So it has three parts to it. We have the short catheter, the reservoir, the one-way valve with the reservoir, sorry, and then the long catheter that goes into the abdomen to allow that fluid to drain. And then that fluid is just reabsorbed naturally by the body. So the valve that's typically kind of like right behind your ear here is going to control the flow of fluid, and it's attached to that short catheter that's going into the brain to pull that fluid away. And then the catheter that goes into your brain can be placed on the front, back, or side of your head. And then the long catheter is also attached to the valve going this way into your abdomen, and it's tunneled under your skin. And so the amount of fluid that is being drained is dependent on what the surgeon sets it on. And there are non-programmable VP shunts. So that's the settings are made in advance by the doctor and they can't be changed. And then there are some programmable VP shunts where the settings can be changed by the doctor. We can go next. So the biggest complications, I'm sorry, I skipped a slide. I apologize. So our troubleshooting is really to know the signs and symptoms of a shunt malfunction and infection, to know to never press the valve, like ever, because that can actually cause a malfunction, and then to always have the number for neurosurgery available at all times. And so when we do have a patient we're supporting at home on hospice, you know, it's important that we do know if they have a shunt, because if they're calling us with new symptoms, it's very important to think through if these symptoms could be caused by a shunt malfunction. Next. And so the complications that we're going to be seeing with the shunt malfunction are going to be the symptoms of hydrocephalus, because the shunt isn't relieving that pressure and allowing that CFS to flow, and it's backing up. So we're going to see and it will be more new or more severe in the spectrum. If our patients are already experiencing some of these symptoms, it'll be more severe or it'll be new. So like a new or more severe headache, new nausea or vomiting, poor feeding when they had been feeding well before, increased head size, the bulging soft spots in infants is a dead giveaway, fatigue or drowsiness, irritability, trouble with balance or walking, visual disturbances, seizures, hypertension, and bradycardia. So again, some of our patients are experiencing a spectrum of these symptoms already. And so we're looking for the changes in these symptoms to see if it could be that malfunction. Next. Another major complication is infection, and we are always looking out for that as well, because we do have a foreign body in the body. So we have fever, redness of the skin around the shunt path, which in this image on the right, you can very clearly see that, swelling around the shunt path or pain. And then what challenges have y'all experienced with children with VP shunts? I think the other thing that I always think about when we do have a patient with a shunt is because, you know, that valve is right behind the ear and that skin is so thin. Really monitoring if they're having that more limited mobility. You know, we're always doing a skin check and really assessing those areas where they could have breakdown around the shunt. So those pressure wounds, especially if they may favor the side where the shunt is, that side of the valve is a very common place to have skin breakdown.
That in practice, that's been one of the most profound things to me when they come in, you know, these kids come in and they'll have symptoms and like they need to come to the hospital, and a lot of times they need to go to surgery. And then they go to surgery and then they're fixed, and it's amazing. But over time, I'm sure a lot of people see that, like you see these symptoms, you know, a lot of times, you know, you talk about things and you have all these symptoms that might have, but these are like, it's like textbook. And when you see them and they come in and dang, they really do have to go to surgery for, like, wow, it's just always been amazing to me how kind of sensitive the brain is, and then wow, they can just go in and fix it.
Yes, and I think, you know, we have a lot of patients who have the shunts, and you know, they're directly admitted to the PICU. They're going in and getting, you know, the shunt series scans so that we can really assess to make sure that there isn't an issue, because they do have to be taken care of surgically so quickly. And these families, they just kind of know, like, we have to.
I was
we get
just
them
gonna
in.
say that the families know, like, it's like, they're like, nope, something's not right, and they're on it, and that's also amazing.
Yes, yes, I know. Our families are the experts and they are truly remarkable. Thank you, Stacy. So next, I'm going to hand it over to Shauna to teach us more about the tracheostomy.
Hi, so pediatric tracheostomy indications, it could be airway obstruction if they have some kind of airway abnormality, tracheomalacia, any airway trauma, airway clearance, neuromuscular disease, chronic lung disease. Airway clearance, if they're unable to maintain their secretions, their saliva, of course, they silently aspirate and it leads to several hospital admissions with pneumonia. And neuromuscular disease, like your SMA type 1, your Duchenne's, of course, as they get older, they progressively get worse and they need more and more support. And then your chronic lung disease or your ex-preemies that were born 24, 25 weeks and they have lung disease. Lungs are still growing and healing. So if they have a tracheostomy, some kids, usually if it's just an airway issue, they don't require ventilation. But some, depending on neuromuscular chronic lung disease, they pretty much always require a ventilator. Home vents have come a long way in the last several years. Next slide. With the tracheostomy, of course, someone that is with the child has to be trained in caring for the child for 24/7. And we always tell our parents that you're going to be the respiratory therapist, the nurse, and the physician all in one to take care of this child. The family, I meet with them several weeks, usually about an hour a day because it is so much information to go over. And you want to make sure they're 100% comfortable taking their child home with this trach or trach and vent. And their biggest fear is always having to make changes to the ventilators. And like I explained to them, they're just going to be managing the vent alarms, but any of the settings they cannot touch. Majority of the time, the DME companies lock the vents, but like I explained to them, any kind of changes, you need to know how it affects their respiratory status. Is their CO2 too low? Is their CO2 too high? So that's sometimes their biggest fear is that they're going to have to start making changes on the ventilator. And so to call for troubleshooting, of course, DME companies are pretty good about putting their numbers directly on the ventilators. So that way the parents aren't having to scroll through their phone to find their number at 2 a.m. But we also suggest that they do store the numbers in their phone. And with our vent-dependent children, they also have an extra layer of support through the ventilator assisted care program that's funded by the state and that's run through Children's Hospital, which is case management for home, but they have a respiratory therapist on hand and somebody's on call 24 hours a day. Next slide. So when you leave with a child, there's a lot of stuff to take with you. I always tell my parents, give yourself an extra 30, 45 minutes to pack up because you have to pack up the child. And then when you get to the car, you have to unpack. And then when you get there, you have to pack. And then, so, with the ventilator, when they leave the house, besides the child, they have the ventilator, they have their suction, oxygen possibly. They have their go bag, which has their resuscitator bag. They have their pulse oximeter. Sometimes they even have the feeding pump. So they have a lot of equipment. So like with our infants, we suggest our parents getting a twin stroller. It accommodates all of the equipment without having to have a small army to go somewhere. And of course, then they have their hosiery bag or toiletry bag that has all their stuff in it to do an emergency trach change. It's red. And that way, if somebody's with them and they don't know what go bag is, they can say, hand me that red bag. So they always have stuff to suction, do an emergency trach change, They have syringes, they have HMEs, hand sanitizers, gloves, scissors, suction catheters, in case a lot of our kids use the closed suction systems. If that happens to break, you need a way to suction, so they have that. Extra HMEs, if it's directly to a trach, they can become clogged pretty quickly if the child has a lot of secretions. And then they always have a trach the same size and one smaller in case they have to do an emergency trach change. And we stress the importance of having this bag go with the child wherever the child goes. The child goes to school, it needs to go to school and come home with the child. They go visit family, it should go with the child and come back. I always like to tell my parents it's kind of like their American Express, don't leave home without it, because it is important. It's going to save their life if something happens and you're in the car on a highway. Next slide. So go bag contacts, we always have a trach the same size, one smaller, trach ties, a syringe for cuff trachs. The one thing with cuff trachs is they have two types, a low pressure cuff, which is air. And then you also have high pressure cuffs that are filled with sterile or distilled water. So the parents also have to have, if they have the high pressure cuff, the TTS from Bavona, they have to have sterile or distilled water with them so they can inflate the cuff afterward. Sterile lubricant, split gauze, tape, the resuscitator bag and mask, trach adapter if needed for resuscitation bag. Sometimes this could just be an OmniFlex if the child does not have a flex end, if they need an extension in order to connect it due to the child's chin. We always have suction catheters. We place the neo suckers or yankers, saline, the bulb syringe to clean the nose and mouth. And then the noses, and there's two. There's the HME, which goes directly to the trach tube. Sorry. And then there's the passive condenser that goes in line with their ventilator circuit and the bottle of water in case they have to clear the suction tubing line. And then we always encourage them to have their emergency phone numbers so that whether it's a physician, they need to call their DME company, that they have it there too. In order to leave the house, of course, they have to have the suction, and it has an internal battery. The battery usually lasts 3 to 4 hours. So we have the parents charge them at all times in case you have to leave an emergency, you have it. The oxygen, some of our kids get portable oxygen concentrators. So the parents aren't having to store 8 tanks in order to leave. They're not having to bring 3, 4 tanks to clinic. If they're traveling a good distance, they always have to leave the house with their pulse ox. The ventilator, it comes with a car charge adapter. So when they are in the car, they're not having to rely on the battery and use up their battery. Also, the vent we use, Trilogy EV300, when they did the upgrade a few years ago, came out with the new version, they extended the life of the battery. So the internal battery and the detachable battery, parents can get roughly up to 15 hours of use out of it without having to find an outlet or hurry up and plug. Let me unplug my phone so I can plug in my vent. Some parents choose to get in the car to travel, the adapter, the inverter, so that way they can plug in the vent, their portable suction, because most cars only have one spot to charge your phone. So some parents do choose to get the inverter so that way they can plug in the feeding pump, the suction, the vent, and they have that for when they travel. Next slide. So with the trach, some of the complications of the granulation tissue, and this is primarily due to the area of around the stoma staying wet. It's very important that it is kept dry as possible. And also you don't want tension on the trach from the vent circuit. That will also cause granulation. And that can also cause damage to the stoma and the cartilage around the trach. We use here it's Maxorb AG. It's an alginate, and we found since we started using it, our granulation has decreased. Treating the granulation, our doctors in-house, we use Odavel eardrops. When they go home, they'll order Ciprodex. And then if it's too bad, of course, they'll use silver nitrate. And if that isn't sufficient, then of course they would go to the OR and have it surgically removed. Infections, of course, you have a direct path to the lungs. So biggest thing is telling our parents hand washing and making sure the trach is covered at all times. Changes in secretions, we go over when the parents should call their pulmonologist or ENT to discuss the changes in secretions. They are thick yellow, green, fluorescent blue, green. And of course, some parents, when they see changes, they want antibiotics, but the kid's not symptomatic. So we try to stress to them, if the kid is not symptomatic, then let it run its course. If they become symptomatic, of course, then we want to treat the symptoms and get antibiotics. We try to stress about developing multi-resistant drugs, bacteria from drugs. Bleeding can be caused granulation tissue. They're full of blood vessels, but they have no nerve ending, so it does not hurt, but they will bleed pretty well. Also with the granulation, if it's too big, it can actually obstruct your trach tube being placed into the stoma. Infection and aggressive suctioning can also lead to bleeding. I try to measure for my parents to tell them exactly how far to go, so they do not cause trauma, sorry, to the airway by suctioning. Mucus plug, we stress the importance of humidification, proper humidification. Some kids that have the trach, they will wear their HME all day, which is perfectly fine. But we stress to the parents at night when they're in bed or in their crib, they should use their aerosol trach collar with their compressor. HME is great for all day, but for 24 hours, it does not provide enough humidification, so it will lead to mucus plugging. Also with the vent, we stress them to check the water level in their heater regularly, because some kids, if it goes dry for 30 minutes, they will get a mucus plug because it is dry. We teach them how to increase the humidification output on the compressor and the heater. So that way, if their secretions are getting thick because the weather changed, they can do that and help try to avoid those mucus plugs and trach changes. Accidental decannulations, biggest thing is making sure your trach ties is secure. However, some people think that you put them so tight that the trach won't come out. That is not true. So anybody less than 3, we like to use 1 finger between the neck and the trach ties, and over 3, we use 2 fingers. The trach can come out. If they're on a ventilator, you want to make sure that there's no tension on the circuit. And of course, toddlers, they like to start grabbing things, and they learn that when I pull my trach out and something beeps, somebody comes. So then some kids, it becomes a game because, oh, mom and dad are at the bedside now because I took my trach out and my vent started alarming. So accidental decannulations. Also, we keep spare trachs at the bedside, one the same size, one smaller, in case they have taken the trach out and it's hit the floor. We want to put in a clean one. But usually if they pull it out, or if it's still secured with the trach ties, we'll just reinsert that trach. We do keep the obturator taped to the head or foot of the bed, so that way you can insert the obturator into the trach that was dislodged and get the trach back in without having to start grabbing a box. Next slide. Any challenges you've had with trachs and or vents? vents presents a whole new challenge because you're dealing with this piece of equipment, and like anything, it can break. Some DME companies are pretty good about putting a second home vent in the house. So that way, if they have one vent malfunction, the parents aren't having to call 911, get to the hospital. They have that vent already set up. They turn it on, put a circuit on it, and place it on the child. So a lot of companies are going that way. We do have a lot of kids that live in the rural areas and, 45 minutes from a hospital. So it's safer for the patient to have that second vent. Also, the other thing is, even with just the trach, power outages, that can be an issue. Our vents, yes, they have internal batteries, but if a child is on a trach collar and they need oxygen, the concentrate is not working, mom and dad may have to resort to their oxygen tanks. But some of our kids, they only have a portable oxygen concentrator, and eventually that battery will die. So that's some of the stuff that we've seen some challenges. I don't know if y'all have experienced any different challenges.
I think those battery issues for our patients who live far away when they're coming here are big issues. I love that do you tell the parents that about the kids pulling out the trach? Because I do think it's easy to sit here and say that it's funny, but they really do that. And they'll be smiling. Sometimes they'll take it out and be smiling with their trach in their hand because they're getting somebody's attention.
I do that because I was an accounting major before a respiratory therapist, go figure. And my nephew was trach vent dependent, and I had learned to take care of him. And my sister and brother-in-law took my older nephew to his ball game, and I went to use the restroom, and my nephew didn't want me to leave the room at that time. And so I heard his vent alarm, and I come running out, and he's literally holding his trach, smiling at me with big brown eyes. So they learn. And so him and I would have a talk before it was just the two of us left in the house.
I love that you share that. That's awesome.
Okay. Well, thank y'all. We're going to go ahead and start with our cases. Next slide, Masood. Just a reminder, we had Stevie and Shauna's input on formulating some of these cases today, but there is always the case discussion submission form on our LMHPCO website. So if you guys have real life cases that you're working through, please feel free to send them in to us and we can all kind of brainstorm together. And obviously feel free to share today if you do have similar cases or questions in mind. Next slide, Masood. Okay, so our first case, you're caring for a 1-year-old patient, Thomas, who experiences trisomy 18 and requires the support of a trach and vent. While you're visiting, his vent begins alarming due to high pressures. Can anyone think of next steps once you just see that alarm going off? And it could be basic. Suctioning, yes.
Yeah, that's what
good idea. And even more first step than that. Like just asking more questions of mom or examining the patient. But yes, I think you probably have already done that, Jancy, like you were saying, and grab the suction. Next slide, Masood. So when we walked in, we saw the alarms, and then we also noticed that Thomas was retracting, having some nasal flaring, DSATs to the low 70s. So showing us that he's having a little increased work of breathing and lower oxygen. He does not improve following suctioning, like you mentioned. And then the next step was trying bagging as well, which didn't help. Oh, sorry. I didn't pause for Shauna. Shauna, So obviously we talked about the exam, suctioning, bagging, and then I kind of gave it away and changing his trach. But do you mind kind of walking us through the step-by-step process that you give to families to what to do when the alarms go off?
Sure. So with vents, they'll have a low pressure alarm, which is a high priority alarm. So that means there's a leak somewhere in the system. We instruct our parents with that alarm to disconnect them from the vent and just start bagging them because it could be something wrong with your machine. The high pressure alarm means something's going on with my patient. So I need to look at the child. Are they coughing? Are they crying? Do I see secretions coming up in the trach tube? So when you pass the suction catheter, do you feel resistance? Can you pass the suction catheter to its normal depth? Or does it feel snug when you do pass the suction catheter? Or the secretions is thick, so let me get some saline, bag and suction. Bag and suction, their sats are up, pop them back on the vent. If they start to desat, then my next thinking is, okay, I have something occluding my trach, I have a mucus plug. The only way to fix a mucus plug that severe is to change the trach. You can continue to bag and suction, but you may never get the mucus totally out of the trach. So when in doubt, change it out.
Did anyone have any further questions about this case or wanted to share stories of things that they experienced that were similar? Okay. And I just want to say, I think it's a combination of Shauna's incredible training and education, and also our parents just really like listening and paying such close attention. But I feel like if I were ever in this situation, thankfully, I know that the parents are going to be like on it right away. And so I'm always so impressed with how they're able to handle themselves when these things do happen. Okay, next slide, Masood. Thank you. So I'll go ahead and read this one and then we'll stay here. Sorry, Shauna. And let Stevia give us her input before we learn more. Okay, so you have recently started caring for your 10-year-old patient, Elizabeth, with a hospice diagnosis of relapsed refractory AML. She has been receiving platelet transfusions 1 to 2 times a week due to severe nose and gum bleeding. Her primary oncology team has requested you obtain a CBC to assess her need for additional transfusion. She has a portacath in her right chest, and you last cared for a patient with a port about 2 years ago. How do you think through accessing this patient's port?
Okay, so does anyone have any ideas to begin with before I start sharing?
I think
And
that
feel
if it
free
had been
to
2 years,
go in the
I'd
chat
probably,
too.
oh, I was gonna say, I would probably look for a policy. And since it's in the home, probably ask the parents too.
Yeah.
I'd be looking for, if it had been 2 years, I'd be looking for a policy to make sure I didn't totally mess something up.
Yeah, and thank you, Stacy. And in the chat, we have Katie saying, ask parents about any special considerations. Jancy said, ask family when it was last accessed. And then Katie's also saying size of needle, etc. And I can tell you, if I hadn't been used to caring for a patient with a port and I'd done it 2 years ago, I would be leaning on my colleagues to help walk me through it. So those are all great, excellent answers. So yes, like we are always going to want to ask the parents, they're the experts in their children, about if there's anything that we need to be thinking through. If you do know that you are going to have to go in and access the port ahead of time, asking the parents to put on that numbing cream maybe before you get there, or when like putting that on yourself right when you get there, because it takes about 30 minutes to an hour to really come into effect. And then you do have usually about 2 hours until it's wearing off. So that gives you plenty of time to make sure that it's nice and numbed up. So we're mitigating as much discomfort as possible. And then again, with the port, we want to palpate it first. This is where we're using our nursing fingers and really getting, feeling the edges of that. So feel and visualize it, knowing how long it has been since it's been accessed and she is home. And again, if it has been a long time since it has been accessed, drawing more of your waist than you typically would. And then of course, doing our typical protocol where we're going to clean it well, let it dry, stabilize it, hold it, because sometimes those ports can be wobbly, and that can add to some of the anxiety with the accessing of the port, because our patients can kind of feel that like wobbliness. So just really making sure that we're having it stabilized and then accessing it. Then again, as we do with our typical port accesses, when we're done, we're going to flush it, heparin, and deaccess it. I personally think that numbing gel is a game changer, and so trying to use that whenever it's available, and other distraction techniques that parents have figured out along the way. Okay, I think we can go next.
Next slide, Masood. So 3 weeks later, you're visiting Elizabeth again, and her primary team has requested another CBC. After accessing her port, you try to aspirate blood. However, you're unable to get blood return. So some questions. What are some initial troubleshooting tips you can try? And if they don't work, what other options exist? Any thoughts?
On it on the chat, and she's saying repositioning TPA. Love it.
Ask the parents if they usually get a blood return. Because sometimes they never get.
Yep. Especially when they are so positional, like they have to be in exactly the right position to get blood return. So right on, Stacy and Katie. I always think about first, like, am I actually in the port and all the way back? Is my needle past that safety threshold? And then positioning, and then trying that kind of pulsatile flushing, where we are just doing it very gently back and forth to see if that we just need to kind of alleviate some of that. And then next would be, after we've worked through our first troubleshooting that we know, we're going to move on to talking about TPA, and like calling a provider to discuss that. And then in the meantime, getting a peripheral CBC from the child.
Next slide, Masood. Or did anyone else have any other thoughts, or again, share any stories of experiences? Okay, next slide. So these are some resources. I'm going to go ahead and send them in the chat. And then as always, they'll also be sent out and listed on the website with the recording of today's session. Next slide. And then just want to again thank you guys for joining. I'm going to send out our LMHPCI Reach website in the chat as well, just as a reminder. And please complete your surveys for if you're hoping to get CEU credit. Our next session is going to be October 19th, and it'll be actually Katie Hilo, who's with us today too, and she'll be discussing management of emotional and behavioral symptoms. So we look forward to seeing you guys then. We'll go ahead and end today with a mindfulness activity. So I'm going to kick it over to Stacy. Next slide, Masood. I think that might be it. Okay. And feel free to email it or send any questions in the chat that come up.
Awesome. Okay, I'm just gonna have everybody stand up for a minute. I don't know about y'all, but I just need to stand just for a minute. If you stand up and do this thing, I don't know if we talked about this before, that superhero pose. It's supposed to increase that stress response for you. And just take a couple of nice deep breaths. I'm just going to tell you, we've talked a lot over the last several months. What are we in? September. So 9 months we've been talking about mindfulness and things like that and what it means and the importance of it in our lives and all the things that it can do. And I don't know that I've focused a whole lot on that, but just reminding yourself that it can be really good for just decreasing blood pressure, decreasing stress, increasing your immune system, all those things. So, and there's lots of different ways. And so I'm just kind of trying to touch on a lot of things, but I've been looking at the VA's website and they have a lot of really cool information. They have a whole health program. They have lots of stuff. So it's kind of looking at that. And there was something that I came across that I want to share with y'all, and it's called autogenic training. Has anybody ever heard of autogenic training? I've never heard it called that, but it was a thing that my mom used to tell me to do when I was a kid, kind of. It was a little version of this. So I thought it was kind of cool that they have a name to it. So it's a relaxation tool or technique that uses the power of the mind to relax the body. And that's kind of what we've been doing in some of these other techniques, but it's autogenic means coming from within, right? Autologous, right? The auto means coming from within. So you're looking, and it's safe unless it does say that unless someone has schizophrenia or severe mental illness. So I'm going to go through some of the things, and I'm going to do it like I've done the other things kind of quickly. So the form of self-relaxation where you're going to be giving yourself, you would give yourself commands, but I'm going to talk you through it. You want to be in a calm spot. So kind of as you settle, get your feet settled on the ground and start taking some deep breaths. Let your breathing kind of settle a little bit. But one of the things they say is to repeat each phrase like 4 times. I'm not going to repeat each phrase 4 times, but if you're doing this thing, if you repeat it, I don't know that there's necessarily a number, but it does specify that if you give yourself a command and it doesn't work, take your time, be gentle with yourself, and do it again. Kind of repeat it, if maybe not more than 4 times. And it also says to pause for 3 seconds in between, but we're not going to do that. And I think you'll still, what I find is it's nice if you have the patience to say it 4 times and take 3 seconds in between. But if you don't, you can still get the effects, the calming effects of these things. So we just kind of take a few deep breaths. And if you're comfortable, to close your eyes and just kind of settle in, feel your chair under your bottom. And if you can, maybe make your breathing a little bit, your exhale a little bit longer than your inhale. Don't focus too much on it. Just kind of settle into that breathing. And the first set that we're going to do is just to think about, just to say, so this command is going to be, my right arm is heavy. My right arm is heavy. My left arm is heavy. My left arm is heavy. Both of my arms are heavy. My right leg is heavy. My left leg is heavy. Both of my legs are heavy. My arms and my legs are heavy. We'll go into the second set, and this one is focusing on warmth. My right arm is warm. My left arm is warm. Both of my arms are warm. My right leg is warm. My left leg is warm. Both of my legs are warm. My arms and legs are warm. My arms are heavy and warm. My legs are heavy and warm. My arms and legs are heavy and warm. I feel calm. My heart feels warm and pleasant. My heartbeat is calm and regular. My breathing breathes me. My stomach is soft and warm. My forehead is cool. I am calm. Taking some nice deep breaths in and just see how your body feels with that grounded, maybe heaviness and warmth, a calmness that may settle in. Take some deep breaths and wiggle your fingers and your toes. Move your head around a little bit. And I'm just curious with that power of suggestion. Remember when we did the first one, which was like this lemon visualization, were you able to kind of visualize your arms feeling heavy and warm? Picture that calmness. I went really fast. That's a 6-step thing. And as you're going through it, I feel like if I were on the other end of that, I probably would have fallen asleep if I'd have been getting to like 3 or 4. So I don't want y'all to fall asleep. But going through that. So my mom used to do that thing, you know, going to each body part and saying it's heavy and relax. So that's autogenic training exercise, which I just think is so cool. And when we have time, like with patients, and even with ourselves, just to give ourselves the gift of a few moments of just breathing, allowing yourself to feel calm and relaxed. Any questions about that?
My arms feel nice and warm.
They do. That's awesome. Even I mean, I wasn't visualizing because I was kind of going through the steps, but I still feel super calm. And I would ask too, if y'all want to think about if there's any of the exercises that that anybody particularly liked as we get toward the end of this 12-month series, if there's any that y'all would want to do again, to repeat, if there was something that popped out. So if y'all would just let me know that, because there's lots of things out there, and some of them I feel like they just put a different name to it, and it's just a little bit different of a technique. But sometimes we hope that it's something that we can incorporate into our daily lives of craziness and busyness, right? All right, well, if nobody has any questions, get up, get some water, and go back to your next thing.
Thanks, y'all. Almost to the weekend. I appreciate y'all joining again. Thank you, Stacy. Always a good note to end on.
Always. Y'all take care.
Y'all too. Bye. Bye, everyone.